As people continue to filter in, thank you very much for joining us on what's another ASES Journal Club. We are this week we are honored to talk about elbow arthroscopy, one of many people's sort of favorite topics, and other people's maybe not so favorite topics. But hopefully after tonight, it will become everybody who's listening's favorite topic, as we are honored to be joined by three of the world leading elbow arthroscopists. People who many of you have learned elbow arthroscopy based off of their teachings and continuing innovation. So Sean O'Driscoll from Mayo, he doesn't need much introduction, but one cool tidbit about Sean O'Driscoll, Dr. Driscoll, is he during his fellowship, he told me that he went probably over 100 times to the lab and really honed his craft with elbow arthroscopy and turned into the master he is today. Dr. Buddy Savoie from Tulane doesn't need a lot of introduction either. He's a master of many things, but his elbow scope experience and expertise is just something that's his experience draws many of us around the world. And then Dr. Peter Chalmers, one of our up and coming leaders in the Shoulder Elbow Society, who also has been really pushing the envelope with regards to elbow arthroscopy. So Clifford, do you want to say anything?
Yeah, no, that was a great introduction, Eric. And, I'll be manning the Q&A session. So if anyone has any questions that they want to ask the panelists, just throw them up there and we'll make sure that you get your questions to them.
Amazing. All right, well, so without further ado, we're going to start out with something I think everybody is interested in and asked about. So the elbow arthroscopy learning curve paper. So this is a questionnaire study that was designed to both look at the trainees, so resident fellows, and surgeons' perspective of learning curves. They ultimately got 323 participants, so pretty good overall participation. 204 of them were surgeons. So if you look at figure 2 and 3, it's interesting. They, with regards to what is that learning curve, or how do you actually be safe, competent, proficient, and then expert? The averages were around 19 for safe, 42 cases for competent, 93 cases for proficient, and 230 cases for becoming an expert, like some of our panelists on this call. And interesting enough. And it's kind of funny, surgeons thought that others needed actually more cases than they needed to become both competent, proficient, and expert. As you can imagine, surgeons often think of themselves in a little bit different light than others. Table 3 is kind of interesting. So if you look at the value of different resources, the highest value was live surgery, obviously, and then cadaveric practice, which was actually rated just about the same as live surgery. There was some disagreement in that the surgeons thought reading videos and formal courses were actually more valuable than the trainees felt, and both didn't really find surgical simulators so important. And interesting enough, all these answers didn't really matter from a surgeon standpoint, whether it was their time in practice, case volume, fellowship background, or their own self-rating of competent, proficient, or expertise. So the kind of interesting study about that learning curve is something I think it sets a nice foundation for future studies on both the actual learning curve of elbow arthroscopy as well as future arthroscopic training methodologies. The hip learning curve was hip arthroscopy learning curve, which is kind of similar to elbow, pretty hard, a little bit more of a niche practice. And it was established as 30 cases, but that surgeons continued to improve up through 100 cases. So Dr. Savoie, what was your learning curve when things really started to click, and when did you feel like how many cases was it when you felt like you were no longer learning as much as you were? So when did that learning curve start to level out for you?
Well, probably right around 100, I think. I had an advantage in that in 1988, I think, I helped teach a wrist course down in Miami, had about 120 specimens, and for whatever reason, they did wrist and elbow. And it's a long time ago. So I just said, what are you going to do with those? And said, I'm going to dispose of them. I gave him the guy that was doing it. I gave him all the cash I had and said, I'll send you a check if you'll ship all these to Mississippi, where I was in practice. And I didn't think anything was going to happen. I didn't have that much money on me. It was a long time ago. And about a month and a half later, suddenly 3 boxes filled with dry ice arrived. Opened the first one, big boxes, and there were 40 elbow specimens in each box. And so I had to go buy some freezers and I put them in. So then what happened during that 88 to 91, when we're really trying to figure out different things, the release part, the arthritis part, some of the different stuff is I would get pathology in and I just thought an elbow and go scope it in because I had enough stuff to do it and kind of sort of pretend the case. And then I would do the case. So I got 2 for every 1. And so back then, I think Sean and I were both trying to develop techniques that didn't exist. And so when you just talk to people at meetings, you say, well, I did this and I did that. And you go, oh, let me go try that at home. And it worked out really well. But I think, I think safety was a big deal, trying to figure out where the nerves were. And then the second and third steps were adding cases in. Some of the stuff we do now, like triceps repair and lateral instability and, ankylosis takedown, post-traumatic elbows, we're going to talk about later, those are more difficult. And so I think the simple things came, 15 or 20 cases. The more complicated ones got into the 50 or 60, and then the really difficult ones past 100 before I felt like, yeah, I can do this almost no matter what.
Fantastic. Dr. Joshua, can you talk about maybe some of the early things that you learned that maybe helped to shorten your learning curve, or maybe advice that you would give to fellows to try to either shorten their learning curve or especially with the more difficult cases, make the steep part of it quicker?
Yeah, it's a good question, Eric. Well, I think some of the things I learned early on were to focus on safety. I very quickly I realized that I had to think not so much about how to do the procedure, but how to do it without cutting a nerve. I confess that early on, I thought that perhaps elbow arthroscopy would never play a role in capsular release for stiff elbows, because I wasn't sure we'd be able to do it and not cut nerves. I changed, of course, my thinking on that over time. But I would say the advice I would give is stay below your skill level, your learning curve. So whatever your absolute limit is on your abilities, and you could think about that like skiing or playing a musical instrument or some other thing that you would do, I would say leave a margin of safety. Some people like to live on the line and they're always pushing the limit. If you're an alpine climber, there's a 10% chance you're going to die, on an ice face or something like that if you're an Everest type climber. I think that for arthroscopy, it's worthwhile leaving a margin of safety, and then gradually you'll be able to accumulate your experience. But the second thing I would say is be aware of ways that you can shift your whole learning curve. You don't want to have to crawl up the learning curve like Buddy and I did. You can shift that very rapidly by a number of things, and there are things that we can talk about that would allow you to shift it. But yeah.
Real quick, what are 1 or 2 of those things?
Well, an example would be learn how to use retractors. Learn how to understand that elbow arthroscopy, unlike arthroscopy in other joints, elbow arthroscopy is first and foremost about your ability to get into the joint and establish a view, and then to create a space in which to work. It's not how do you shave bone, or how do you put a screw here, or how do you dissect this or anything else. It's really how do you get everything all arranged so that you can do it safely. And we'll see that when we discuss some of the papers tonight about even getting into the joint. So focus on those skills. If you want to practice and learn something, practice the technical skills of getting in and establishing a view and creating space in which to work.
Fantastic. All right, Dr. Chalmers, I'm putting you on the hot seat a little bit. So you have somebody who has shortened the learning curve and has become a very technically gifted elbow arthroscopist in a very short amount of time. Can you talk about your journey in taking what Dr. Joshua and Dr. Sova did, and how you've gotten to the point you've gotten so quickly?
I'm feeling like I signed on to the wrong podcast. I don't consider myself like particularly technically distant when it comes to elbow arthroscopy. And I consider myself like very much in the midst of the learning curve. It's funny. I mean, I am really honored to be here, and in some ways I feel like I don't belong here, but in other ways, I think when we talk about the learning curve, it's really helpful to talk to someone who's in the midst of it, who's still learning, because I feel like I'm definitely still learning when it comes to this procedure. Well, I think what everyone's mentioned is true, which is that this is a dangerous procedure, and I think it should be treated as such. The thing that I think is super interesting about this paper, from a more global perspective, is it shows that you need 42 cases to be competent. And the challenge I would give is, how many of our residency programs provide 42 elbow scopes before you graduate? How many of our fellowships provide 42 elbow scopes before you graduate?
Yeah.
So the issue here I have is like, I think this data is accurate, but what does this say about our ability to train people to do this procedure? And to me, I think that plays back into what you led from the beginning, which is that this is a procedure, if you want to become competent, it requires you to work on cadavers. It's like necessary. And you've heard that already from both of our panelists.
All right, so maybe everybody, what's the future of arthroscopy, elbow arthroscopy education? So cadavers is great, and shoulder replacements, we're getting like mixed reality and virtual reality, and in rotator cuff, there's synthetic models. What's the future of elbow arthroscopy education? Because at some point we have to shorten these learning curves. And as you mentioned, not every fellowship is gonna go and with Sean or Buddy and just do 50, 60, 70 within that fellowship here. So what's the future among, and anyways, welcome to chime in, of how we are going to help our trainees going forward.
So if I may, I would say that of course, augmented and virtual reality and simulators are the wave of the future. There's no question. The problem with the elbow is that it's a relatively small group around the world, and everybody knows each other. And usually the companies that provide that kind of advancement in knee, shoulder, hip, with the robots and the augmented and virtual reality, it requires a significant investment. And what you see over and over again in the elbow is that the companies would say there's not a market and there's not enough to do it. And so while I think it's probably the joint that would benefit the most from that, I think we're going to have a hard time moving that forward. And it's the one joint that I think that cadaveric practice is going to stay the same. And that once you have an interest, then you're going to go visit Sean, you'll go visit Peter, you'll visit folks that do a lot of these things all around the world, Denise or Roger or some of the folks in Europe, and learn how to do it that way and practice on your own. I worry that the resources needed to step it up into the virtual reality world may not be allocated to the elbow.
Yeah, I would agree with that for sure. When you think about people landing aircrafts and so on, they don't generally try that out on a multi-million-dollar device, do they? But I would add something as well to encourage people. When I teach people, I tell people that I think that elbow arthroscopy is probably 90% cognitive skill and 10% technical skill, meaning that the skill of moving around, the skill of knowing how to do a certain thing is much more about knowing that that's something that somebody does or can do than physically executing it. You do have to get the muscle memory. You do have to learn how to execute it. So you do have to get that eventually. But the much greater asset to require is the knowledge base, the familiarity with all those things that can be done and what they look like when they are done and executed well. So I'm confident that people who come as an observer for quite an extended period of time and then go back home are able to acquire those skills and become expert level arthroscopists much, much, much faster than somebody who maybe got a chance to have their hands on a lot, but wasn't exposed to that cognitive training part.
Fascinating. Anything else, or Clifton, do you want to go to that next one?
Yeah, absolutely.
Parlays nicely.
Yeah. So the next one is titled Elbow Arthroscopy, Early Complications and Associated Risk Factors. The purpose of the study was to investigate early complication rates after elbow arthroscopy, identify risk factors for adverse events. It was a retrospective review looking at elbow arthroscopies performed during a 13-year period, identifying perioperative complications. There were 417 procedures. There were minor complication rates of about 8.9% and major complication rates of about 4.8%. The rate of superficial and deep infections were 6.7 and 2.2% respectively. Major complications include 9 deep infections, 6 cases of HO requiring further surgeries, and 4 manipulations under anesthesia. There were 7 transient sensory nerve complications and no motor deficits. There were no differences in complication rates between low, moderate, and high complexity surgeries, interestingly. And then also they evaluated intraoperative steroid injections, which were strongly associated with postoperative superficial and deep infection rates. in elbows over ones that were not getting intraoperative steroids. And they conclude that complications of elbow arthroscopy are seen in approximately 14% of cases, although most are minor. They said the major complications were about 5%. They also concluded that case complexity did not correlate with complication rates, and steroid injections increased infection rates. So first question is for Dr. Chalmers. When you're setting up your portals, do you want to just go over your initial portal placements for a standard elbow arthroscopy and what you do to minimize nerve injury?
Yeah, I mean, I guess I should, full disclosure, I mean, I was a WashU, this is a WashU paper. I was a WashU fellow in 2016. This was in 2014. So like the findings of this paper were close on everyone's mind when I trained there. And so we talked a lot when we did elbow arthroscopy about how to avoid complications. So what I've been doing, and I think that this is, I'm not inventing anything new in this regard. You know, I use a very standard anteromedial portal, and then I need to localize from there. And those portals are the ones that are the riskiest. And I think the anteromedial portal is risky for, you know, median antepercutaneous, but also the median nerve, which can be close by. And then obviously the radial nerve on the lateral side. And then posteriorly, I think your primary concern is the ulnar nerve. And this is one thing where I actually do things slightly differently when I was taught in fellowship. And I went after fellowship to visit Jimmy Andrews and watched him do several elbow scopes, and everything was different. He was doing them basically upside down as compared to how I'd seen them. One of the things that he did that I thought was really interesting, though, is that he moves his posterior medial portal more close to the nerve and then turns the shaver entirely away from the nerve for the entirety of the debridement, instead of making a midline trans triceps portal. And the thing that's beneficial I found about that is that then you never have to have the shaver turned towards the nerve. The shaver can always be turned entirely away from the nerve. So that's the only alteration I've made, to be honest, other than the things that I've already learned from Professors O'Driscoll and Savoy.
Fantastic. And so, you know, Dr. Driscoll, when I was learning from you at Mayo, you know, you used a lot, as you've kind of hinted at, you talked a lot about becoming a good arthroscopist was paying attention to complications and knowing like how to avoid them, knowing knowing when they happen and how to avoid that. So can you talk to the fellows out there and as they start doing this on their own, can you sort of maybe teach them, like you do your own fellows, like what are some of the most important things to consider besides maybe just anatomy about how to avoid some of these common complications that we read about in this?
Yeah, well, thanks, Eric. You know, people are always worried about the nerves. I think maybe the first thing would be to understand, how do nerve injuries occur? So that would be talking to people like me or Buddy or anybody who's done a lot of arthroscopy and finding out what our experience has been with nerve injuries in our own hands. And then secondly, what has been reported in the literature. Ideally, it'd be nice if we could know the circumstances of every nerve injury, but we're not going to be able to know all that necessarily. I don't think nerve injuries occur very oftenly while establishing portals. That was in the early days that they did. And I think that nowadays that must be very, very uncommon. I haven't heard of such a thing happening in quite a while. I don't mean it doesn't. I imagine it does. But I don't think that that's really the risk. I think avoiding nerve injury is about not doing something that could damage a nerve, meaning shaving, cutting, radiofrequency ablation near a nerve. So what does that mean? That means knowing where the nerves are in 3D. And that goes back to what Buddy said about cadaver work. I would encourage you that if you're going to be interested in elbow arthroscopy, that you use cadavers to be able to create in your mind a three-dimensional map of where the nerves are. Now, I also imagine that pretty soon, if it's not already the case, you might not even need cadavers for some of that because of all the 3D modeling. It's just unthinkable what that would have been like for us, 30, 35 years ago, to have been able to spin something around in three-dimensional space and then know where these things are, as opposed to, figuring it out in our minds based on x-rays and some cadaver work. So know where the nerves are in 3D. And then while you're working, fix in your mind the landmark. So what do I mean by that? Imagine that elbow arthroscopy is computer navigated surgery and you are the computer, and the various landmarks, bony landmarks, are registration points. And so you register them, and now based on where they are, the nerves will be in certain locations. And when you know where the nerves are, then you know where the nerves are not. And you can do your work safely where they're not. And as you get closer to where they are, then you become increasingly attentive to a higher level of safety with what it is you're doing, turning your shaver away, never having the shaver connected to suction anywhere near a nerve, things like that.
Fantastic. And Dr. Shabbat, so where do you find that when people are first learning that they're at the highest risk for getting some of these complications? Maybe it's HO, maybe it's nerve injury. Like, what are some of these common pitfalls early on, or as people are progressing from safe to competent to experience that you see happening, and what advice would you give to avoid that?
So I think I would piggyback on what Sean said, is understand your three-dimensional anatomy. So if you're going to do an arthritic elbow, for example, and there's a large medial spur, we move that proximal anteromedial portal more anterior. And actually, I do that on almost all of them because I think it's a safer, more safe portal, so you don't cross and hit the median nerve. So I think that's one thing. The second thing, which is really simple, everyone found that superficial infection rate. They did it at the Mayo study. We did it with ours, and we did it with Ken's, was always related to the lateral, mostly soft spot portal. So put a stitch in that portal because that's the one that drains pretty readily. You always think in terms of the big complications, but an infection can be just as bad, and you certainly don't want to have it. And one simple stitch would avoid that in that soft spot portal. HO, on the other hand, it's a bit of a dilemma. You talk to Ken, he would tell you that he put cortisone in every one of his elbow scopes. And although he had a couple of infections, he had no HO. So then you're trying to balance this. So if you're doing an arthritic elbow, you're taking out a lot of bone spurs, and there's a lot of stuff going on, or post-traumatic, and your risk of heterotopic ossification is higher, you may want to use indocin. You may want to use doxycycline as a cytokine inhibitor, even prednisone if you don't feel comfortable injecting it. The other thing is, if you're doing big stuff, you may want to put a drain in. Sean likes to do big portals and let fluid come out on the floor, and so that drainage will come out. But if that seals, you want to get that hematoma out. So put a drain in and pull it out, in right before they go home, or leave it in and bring the patient back the next day. So there's a lot of ways that you can avoid some of these complications. The nerve part has been very well talked about by Sean, so I wouldn't add to that.
The next question is actually from Mike Gottschalk, who's the chief of upper extremity at Emory, who said, do the current panelists use HO prophylaxis routinely on any of their patients? And if so, what do they use? Okay, since I've already said that, I'll take it first. If I think they're high risk for heterotopic ossification, then I put them on indomethacin 75 once a day. I put them on prednisone 5 milligrams once a day. And then I put them on doxycycline 100 milligrams every day. And I'll do that for 3 to 4 weeks. And I do that primarily on my really bad arthritic ones and some of my post-traumatic. I know we're going to talk post-traumatic later, but I also do it on my post-traumatic ones. I think those are my high-risk patients. And then the third group would be anybody that has had heterotopic ossification. Can be a completely other area of the body, but a completely different area of the body. If you had a history of heterotopic ossification, you get those 3 medicines. So those groups routinely get HO prophylaxis.
That's fascinating.
I've been using indomethacin 25 TID for 3 weeks.
For 3 weeks. And for everybody, or for the high risk ones, or how do you differentiate that?
Any of these contracture releases, anybody in whom I work on bone or do a contracture release, or who has anything else that we would think of as a risk factor for HO, or who's had HO before. The ones who are very high risk, such as those who have had it in multiple joints, have had it as a recurrent problem in the elbow. I consider radiation. So let's say I did an arthroscopic procedure on somebody, they had HO. I took HO and they got it even worse HO. Then I would consider radiation. I used to routinely do it. Now I'm a little bit less likely to, but I still consider it.
Fascinating. Chalmers, do you do anything routinely?
I've been doing naproxen. I don't know if it's not enough, but I haven't had any problems. I've been naproxen. I've been doing 500 BID for usually it goes for 3 weeks. I know that Indocin is like the industry standard, and I was using it for a period of time, but I had a fair number of patients complain about it. I switched to naproxen. I've had no issues with HO and have had fewer patients complaining, but I'd be curious to hear the other panelists' thoughts. Do you think I'm not doing enough?
I have no idea about that, Peter. I used the indomethacin based on the early literature for hip work and figured that I'm not an expert in it in a way that I'm going to be able to come up with something new. So I just followed what was being done. I will share that my sense is that HO is probably neurogenically mediated. And so I'm much more concerned about nerves than I am about other things in relation to both the cause of HO and preventing it. But so I've wondered, for example, should I be putting people on gabapentin, for example, or other things? So I don't know the answer. I also give everybody vitamin C. I tell them, unless they've had calcium oxalate stones, to take a high dose of vitamin C every day for the first 3 weeks following surgery, just in the event that that might modulate their immune system and thereby the neurogenic mechanism for HO that some people think exists.
Is anyone using steroids? That was a new. We never do here. I never was trained that way. It's interesting. In today's practice, is anyone actually still using steroids intraoperatively?
So
we're using dexamethasone IV, but I'm not using it like into the wound. Is that what you mean?
Yeah.
So, Buddy, or Dr. Sawai, you mentioned you do it post-operatively for 3 weeks, correct?
yeah, Buddy is fine. And yes, I will put them on 5 milligrams prednisone on a daily basis. So you're talking about sort of end stage, really stiff elbows. Most have had prior surgery. So there's sort of two answers to this. Yes, when I see these patients and I think they're high risk, they get 3 medicines. So the steroid is like a super anti-inflammatory. You know, Peter, naproxen may be fine. I don't know. I'm like Sean. The old literature says indomethacin, so we use the indomethacin. The one change over the last maybe 10 or 12 years is that we did some research on doxycycline, and it is a cytokine inhibitor. And if you think that inflammatory cytokines may play a role in heterotopic ossification, then that's a good thing to do. Plus, it kills C. acnes. So you kind of get the best of both worlds there. I actually don't have a problem injecting the elbow. Have not had that associated with an increased risk of infection. But again, we close the lateral portals all the time. And if we're worried about it, we'll use a drain. The only time I use radiation is when I'm taking out HO early. And we'll do that arthroscopically. So if I operated on someone and the first visit is great and they have full motion, and they start to stiffen up and it's not an ulnar neuritis, which Sean has taught me about, then I'll go back in, take out the HO arthroscopically and irradiate the elbow. And that seems to work out pretty well. I don't routinely use the radiation.
Awesome. I was saying, and Gotchak mentioned this in the questionnaire or in the question answer. We've started doing dose packs on like almost everybody, and we have a paper coming out on RCT and shoulder replacements. But we've started doing that just as a 5-day or 6-day taper. But do you think it's important to go for the 3 weeks? Is it too short to just do the 5-day taper?
No idea, actually.
Yeah.
I have no idea. This is not scientific data. This is, I think
Sure.
I need to do it this much. What I see is most of them get a little stiff around 3 weeks. So I just do it past the 3 weeks and they don't get stiff at 3 weeks. But really, there's no evidence on this. This is just a feeling.
Yeah, fascinating. Well, let's move on to a topic I think all of you are hinted at, and I think a lot of people have anxiety with regards to. So this is the post-traumatic elbow. So this is the article that's comparing the sort of retrospective review of osteocapsular arthroplasty done either open or arthroscopically in post-traumatic setting. And it's looking at from an open standpoint, arthroscopic standpoint, is there a difference? And it's looking at the prior fracture types. Are there a difference in the ultimate outcome? So they looked at ultimately 44 participants, 13 arthroscopic, 31 open, relatively even divide between inter and extra articular fractures back when the fractures initially happened. Interesting enough, they did have a fair amount of exclusions, 28 exclusions. And naturally, there's some biases in this study. Nonetheless, I think it brings up a really interesting debate and point. In general, open arthroscopic did very well with regards to overall delta changes for range of motion, for VAS, and for the Mayo elbow performance score. There was relatively short-term follow-up, about 2 to 3 years in each group, but nonetheless, they both improved. Potentially, the arthroscopic had higher ultimate values, but the open started at a lower value and had very similar overall deltas. The one real interesting finding, and it kind of makes sense, is the interarticular fractures ultimately did worse than the extraarticular fractures, regardless whether you did open or arthroscopically. And in general, there wasn't a big difference in complications, although there was slightly more heteroscopic ossification in the open ones. Naturally, that could be a confounder, given that potentially the open ones had a little bit more complicated pathology to start out with. So kind of interesting comparative study. Really, the idea is you have a post-traumatic elbow. This is the one that I think a lot of people have some anxiety about. This also is the one that's that I think the complication risk / the risk of not actually giving them as much function as you're hoping to really comes to play. Naturally, the study has a lot of confounding factors, and we don't have to necessarily go into it. Really, it's comparing apples and oranges in a lot of respects. But nonetheless, I think it brings up an important point. So, Buddy, maybe let's start with you. When you are working through your algorithm, and I know you have really pushed the boundaries with regards to arthroscopic, do you ever open anymore? Are you only doing arthroscopic? And when somebody's starting out, when they're deciding some of these deformities, taking down some of these big post-traumatic deformities, how do you recommend that they sort of balance open versus arthroscopic, anterior, posterior, et cetera?
So I think the biggest thing to remember is you should do what you do best. I agree with the outcome that there's not a lot of difference between a well done open, whether you do medial or lateral column approach doesn't make any difference, and an arthroscopic approach that's also well done. So for me, the open ones are almost always based on taking out a medial plate that's under the ulnar nerve. The trauma surgeons now put that medial plate on and it bends right underneath the nerve. I do not know how to get that plate out arthroscopically without protecting the nerve. Lateral plates I actually take out with a scope, so that's irrelevant. So if they are on the outer side and they come up on the humerus, those are all done arthroscopically. I think the one advantage of the scope procedure, whether you start above the joint and are comfortable with that technique that Srinivas Kamanini and I wrote up, or not, really keys, can you get in the elbow? As Sean talked about at the very beginning of our journal club, do you feel comfortable getting in the elbow and understanding the three-dimensional anatomy of what's going on? Because in trauma cases, that anatomy is distorted. And my nerve complication that I had way back a long time ago was a radial posterior osseous nerve injury from a displaced radial head fragment, where I actually released and excised the capsule, but that fragment was scarred to the nerve on the distal anterolateral capsule. And as we straightened the elbow, it basically tore the nerve in two. And we had to go back and we had to look at it. And I went, oh my goodness, Sean knows the story. I quit doing capsule releases for 6 months and did nothing but dissect elbows, tried to figure out what's going on. Turned out Daryl Harris had the same thing happen to him open. But it wasn't until I ran into him and we started talking about it that we figured that out. And so I think knowing where your potential snake pits are will direct you on what you want to do. So if you're comfortable arthroscopically starting on the proximal humerus, using retractors as Sean has taught us to bring the neurovascular structures out of the way, and then you can excise the capsule all the way down into the joint, assuming that capsule is adherent, then that's fine. If you're not comfortable doing that, open the elbow, find the nerves, and protect the elbow.
No, that's great advice. So Peter, let's jump to you real quick. What factors do you think, in your mind, predict a worse or more difficult outcome arthroscopically, and maybe will push you to at least augment it with an open? Or is there anything that you can look at preoperatively to sort of help make your decision on the two different approaches?
Well, I think you've heard some of them already. Certainly if there's a prior open procedure, if there's a prior hardware in place distortion of the native anatomy, a greater degree of heterotopic ossification, or again, like as you heard with Buddy's story, like pieces not where they're supposed to be in the osseous anatomy. But I also think that it's, for people just starting out, this is not a good one to start with. You know what I mean? Like if you're working on your skills, like I think you want to start on, the loose body or the OCD, and then maybe work from there to arthritis. And I think you need to feel very comfortable with just primary osteoarthritis before you think about a post-traumatic or this kind of situation. And to me, part of what comes to play for me, and again, like this is because I'm not the master of the other two panelists here, but like I think the range of motion you start with matters for how comfortable you're going to feel with this. Because as you heard Buddy mention, if you've got no elbow to begin, no range of motion to begin with, if you've got nearly complete ankylosis, you're not going to be able to get into the elbow. You're going to have to start extracapsular. And that's, like we're all comfortable with that in the shoulder, with subacromial work or scapulothoracic work, but it's very uncomfortable at first to do that in the elbow. And so I think it just takes a lot more experience to get there. I mean, I think that's more on the expert stage. That's certainly not in the competent stage of your learning curve.
That makes sense. Dr. Driscoll, can you expand upon what they have been teaching us about this? So what changes in your mind in this post-traumatic setting? You mentioned the cognitive aspects of this. This is probably where it's most important, maybe more so than almost any other setting. Can you talk about some of that with regard to this really difficult pathology?
Yeah, I'll try to paint a picture if I may. You want to try to get to a point where you feel that what you're doing in this particular elbow right now is familiar to you, meaning that you know where things are, you know where things aren't. But as you're starting out, it just like, Peter just said, you may not be able to see any of the structures in the elbow. So we just did one last week as a good example of post-traumatic. And I'd done the back of the elbow already. I went to the front of the elbow and everything was, pardon me, severely scarred right down at the articular margins and into the articulation. So, and there was also some deformity about. So I was virtually certain in my mind, what I mean to say is that if Buddy and I were both in the room, we would agree, yeah, we know exactly where we are. But as I teach people, it has to be evident to somebody watching a video recording of your scope. And so I felt it necessary to teach my fellow at the time, okay, well, how do you go from where I'm pretty sure, but you wouldn't be as sure? And so I said, we've got to be able to confirm that that's the capitellum we're looking at and not the trochlea, for example. So I brought a smooth retractor up through from the soft spot, up through the radiocapitellar joint to emerge right between the radial head and the coronoid, right at the PRUJ. And then, tickle it up into the space. You can see the tissue move and then poke it through up to where I was. So that gives me a landmark to be able to work from there. And then I could strip over across the capitellum, expose that, see the movement of the radial head and say, okay, so now we know for sure where we are and where we aren't. It's that cognitive aspect of, in essence, when I was trying to figure out how to teach people to do this operation, which took me a long time to figure out how to teach, it was the most difficult teaching challenge in my career. I realized that what was going on in my brain, I'd be interested, Buddy, in what was going on in your brain. I realized that I had certain milestones I was trying to get to. I was focused entirely on registering anatomic landmarks that I could be certain of their identity and the orientation of which way was up and down and so on. Then the next landmark milestone I was trying to get to was I need space in which to work. And everything I was doing was going towards that objective. Then I did the work that I came to do, whatever that work was. And so I'll ask people, I may be removing some bone and I'll say, what step am I in? Am I in step 2, which is creating a space in which to work, or am I in step 3, which is bone removal? And if you're cognitively really aware, you realize, no, actually, I'm in step 2. I'm not removing this bone for the purpose of removing the bone. I'm removing this bone for the purpose of creating space. Does that make some sense? Because that'll affect how you think and go about doing it. It's hard sometimes to paint a picture of what's in my brain, and share that and get that into your brains as well, all the fellows out there. But that's the concept, is you want to get to a familiar place, reduce or convert this complicated case into a case that now does not seem complicated. It seems like every other case once you've got to that stage now.
Yeah. Oh, that's fantastic. So kind of going along that lines, so buddy, if you want to kind of add to that, in the post-traumatic setting, let's say that you're at the proficient stage in your learning curve, and now you're kind of progressing on this step. It's hard to simulate a post-traumatic elbow in the lab. As you progress through this part, because this I think is probably the hardest part of any learning curve, and arguably one of the biggest advances we have in elbow arthroscopy is being able to do these really complicated post-traumatic ones through the scope. What do you, can you add on to what Sean just talked about on getting through that learning curve of tackling these more and more through the scope, and you know, maybe like how you start, like starting anterior, starting posterior, like what are the ways that you can really master this technique?
I think first, set a time limit. So one of the things you don't want to do is be operating on an elbow for hours and hours and trying to scope it and have it get bigger. So one of the things I tell folks are two things I try to teach my residents and fellows. One is, if you're doing this on your own, then you want to set a time limit. Maybe it's 60 minutes, because usually for elbows, I set 60 minutes and figure I should be the majority of the way through the elbow. The second thing is, when you're dealing with really complicated things, what part is critical that you think you want to do arthroscopically, and what part do you feel you can do open? So I kind of teach the opposite of Sean in terms of anterior and posterior. So for me, I would much rather get the entirety of my anterior procedure done and have all of that out, know that my median nerve, brachial artery, my vein are all the way, the radial nerve is out of the way, and I've taken down the anterior capsule, because posteriorly elevating the triceps and cleaning out the fossa, as long as you know where the ulnar nerve is and you dissect it out, the swelling doesn't really affect that part of it. Whereas if you work posteriorly and you're not efficient, and Sean is very efficient on his posterior releases, but if you work posteriorly and you're not efficient, then moving to anteriorly and everything is worse and your anatomy is distorted, you have more potential damaged structures. Whereas posteriorly, from the ulnar nerve all the way back around to the radial nerve, you're pretty safe. So think about your risk factors and where you're comfortable. Most people are more uncomfortable anteriorly than posteriorly. And if they know where the ulnar nerve is, make a little incision, hold it out of the way, and then you can elevate your triceps, you can clean out, you can take plates out, but you've already done the front part. Now you have your extension. So, and then the other thing we talk about, we do what we call Wednesday night debriefing. We finish all of our Wednesday cases, and then we sit down and go over indications, what you did right, what you did wrong, and how this works. And one of the things that I think is absolutely critical on the elbow, and Sean alluded to this, is I need you to have a plan. I need you to have the 10 steps or 11 steps and a time frame in your head with a clock ticking that says, this is step one, not rushing, not hurrying. Complete step one, then go to step two. Complete step two, and then you go to step three. So establish a portal, create a space, take out your medial osteophyte so you have access to the front of the elbow, work your way across, know where that radial nerve is, stay away from that fat stripe, and keep either find it and protect it, or stay away from it and continue your release all the way across. So I think having a plan and sticking to that plan in a time situation, because where people get in trouble is when they don't have a plan, they start kind of moving around a little bit and then have a problem.
All right, I think that'd be super helpful. Do you mind just going through really quick in 1 minute, just your step 1 to step 10 of a post-traumatic prior distal humerus fracture stiff? Like what is that? What are those 10 steps? Oops, I think you're muted, buddy.
So for me, first, I mark the ulnar nerve. Number 2, I'm going to try to insufflate the joint, usually from a soft spot portal, and try to make sure I'm right in that radiocapitellar and ulnar triangle. If I can get in there and see if it dilates. Most of my post-traumatics are really bad, and so the capsule is adherent. So then I'm going to establish a proximal anteromedial, proximal lateral portal. So number 1, position. Number 2, know where my ulnar nerve is. Number 3, see if I can dilate the capsule. If the capsule doesn't distract, Then I establish a proximal medial and a proximal lateral portal, retract the brachialis anteriorly, and then I clean off the anterior surface of the humerus with a side effect cautery. Then what I usually do is I will follow the lateral capsule down until I find the top of the capitellum. And then I'll clean across the coronoid fossa and then see where my medial spur is. Now I have the capsule excised and I can look at the joint. So it's pretty easy. There's the radial nerve, median nerves more anteriorly. I'll retract them as Sean taught me, and I'll excise the capsule. And at that point, if there's any bony changes, we take those out. That's step 4. Step 5, once we've completed that, is we're going to establish a posterior central portal, can be a little close to the ulnar nerve, and a posterior lateral portal, and I elevate the triceps all the way up. If there's metal there, and I plan to take out the lateral plate arthroscopically, we'll do that at that point. Then we'll come down, make sure the fossa is cleaned out, go release part of the posterior band of the medial ulnar collateral ligament, and then come down the radial gutter, suck that part away, and excise it down until I get to the radial ulnar humeral ligament, and then clean out the joint coming back up. So mine is anterior to posterior. So number 1, create my anterior space. Number 2, dissect down to the joint. Number 3, identify the capitellum and the trochlea. Number 4, release and excise the entirety of the anterior capsule. Number 5, go to the back, mark the ulnar nerve. Number 6, elevate the triceps. Number 7, take out any offending metal that we can do arthroscopically. Number 8, ulnohumeral release in the olecranon fossa. And number 9 and 10, go down the lateral gutter, excise the tissue, and then come back up the joint.
Fantastic. Awesome. Dr. Driscoll, can you add to that real quick? I know we're going over time on this article, but I think it's really valuable. Either do you want to go through your 10 steps or maybe add to what Buddy just said?
So one of the things you have to realize about Buddy is that he's so extraordinary a thinker and so incredibly technically skilled that, you know, he can convert a 232 step operation into 10 steps and so on. And, you know, so, you know, he has an extraordinary ability to communicate that way. And my sense is that in order to learn and communicate that I find it helpful to think about blocks that don't change. So for example, depending on circumstances, that step might not even be necessary. You might go in and you might go straight and you don't have to come. On the other hand, you might spend 25 minutes executing that one step and require a whole bunch of additional technical things. And Buddy and I know that. So it's hard to describe it in every single detail. So I have these milestones that I think we can all recognize that now we've repeated. So I think of everything in 4 steps: get in and establish a view. And that has a multitude of technical steps that you might require for it. And sometimes it's the most difficult part of the operation, like the one I just referred to from last week. Number 2 is to create a space in which to work. And that is, generally speaking, where the majority of your skills are going to be required. If you're going to be playing a sport, a competitive game, and you got to win the game, that's what's going to determine whether you won that match or not. Those are your skills coming out there in creating the space in which to work. And then number 3 in these elbows is the bony work. And then number 4 is the capsular work, capsulectomy. And that's just so you don't remove that capsule, if you don't have to, that is, before doing all this bony work, because you got to clean up all the bone debris and you get more swelling. Sometimes you have to do the capsulectomy in order to get to the bone, as Buddy just said. So it's those milestones that we've got to get to that I think of it as. And then there's a multitude of different tools for each step. It's kind of like building a foundation. If you're building a foundation in Miami, it's different than in New York, different than San Francisco, where the earthquakes are and so on. But the principles, the engineers would agree on what they've got to accomplish with that foundation in any of those scenarios. But how they accomplish it, the tools they use will be different.
Amazing. All right, real quick, Peter, as you've learned to do these post-traumatic elbows, can you say one thing that's probably one of the most important things that you've learned as you tackle these?
Yeah, I mean, I think that the one thing that I learned about this case that was like the most important was the first thing that Buddy mentioned, which is, in this case, your day is going to be determined by when you try and inject. And when you try and distend the capsule, you're going to know immediately how difficult is this going to be? And this is the step at which I've definitely had elbows where I thought, I'm gonna do this arthroscopically. I got zero distension early on in my practice, and I said, let's just do this open. The better part of valor is to get this done. So I definitely would give that piece of advice to people, that if you go to a distend and there's zero distension, that's if you're feeling uncomfortable, that's a time where you may say, okay, well, maybe we cut our losses here and see what we can accomplish open. And I hate to say that in a journal called about arthroscopy, because it makes me feel like I'm a failure, but I think it's true. Yeah.
Wonderful.
The model partner, Larry Field, used to say there's no arthroscopy police. Nobody's going to penalize you for opening something and doing something. If it's more safe to do it open, you should do it open.
Yeah.
We have a question from Matt DePaula here, and this is for the panelists. He says, what are the indications for a radial head OA? He said it fits more with OA indications, or is it something that the experts address, where sometimes patients have no cartilage, but you still choose to leave it alone, and sometimes you address it. When do you address the radial head?
I guess I go first. So for me, loss of pronation, supination, and deformity, and that's their main complaint, I usually will take out the radial head. If they're a bench presser, never take out the radial head. I'd rather take spurs out front and back because they're more interested in flexion extension. And, the radiocapitellar joint does pretty well with microfracture. So to me, and this is a change, because early on in my career, back in the late 80s and early 90s, I did a fair amount of radial head excisions. Some shouldn't have done. Some were bad rheumatoid deformity where they had no pronation and supination. So I would say that that's it. If their main issue is pronation and supination, and it rarely is, because you can move your shoulder and accommodate that. But if they're saying, I need to turn my hand up to go to the bank or do whatever, you can do that with the partial radial head excision. And then the big question is, if it's radiocapitellar impingement, you can really take out 5 or 6 millimeters and they'll be fine and preserve that part. If you cannot, then you take it all the way down to the radial neck. You can actually go all the way down to the biceps tendon if you have to, but better not to do that.
Fantastic.
I think of three times when I would take out the radial head. One would be if the radial head is the cause for the problem. The typical example would be a 13 or 14 or 12-year-old patient in whom there's been a Salter-Harris type 4 radial head fracture and now has inflammatory, erosive, destructive changes in the elbow and a severe contracture. So I think that's got to go. The second would be if the radial head is a severe block to motion due to the deformity of the head itself, such as is sometimes seen in rheumatoid arthritis, not commonly, but sometimes it is. And then the final is that if I'm convinced that the radiocapitellar joint is the cause for the pain, and sometimes that's an arthritic elbow that I've left the radial head in, I've done everything. And now they come back with great motion and they got this terrible pain with screwdriver work and so on. And it's right at the radiocapitellar joint. But I try to avoid taking it out if I can.
Fantastic. Chris,
I've made that same mistake, Sean. You leave it in and all of a sudden it's like this and you go, very frustrating.
The one I would add is, and I work at a children's hospital here. There's definitely patients with congenital deformities here that can benefit from radial head excision. That's a unusual subpopulation, but it does exist.
I forgot. That'd be number 4. You're right.
All right, awesome. So maybe I'll go on to the last article. I'll try and go through it really quick so we can just get the panelists in our last few minutes. So it's arthroscopic versus open lateral release for the treatment of lateral epicondylitis, a prospective randomized controlled trial. Great study designed to determine whether quality of life and function was different after open versus arthroscopic debridement and pathologic ACRB treatments. So it was prospective. The study included patients over 16. They looked at PROs, DASH, visual analog scores, patient rated tennis elbow evaluation, and they looked at them preoperatively at 3, 6, and 12 months. They evaluated grip strength. They all had the same PT program. 37 patients were randomized into the open group, 38 to the arthroscopic group. Both had, there was no significant difference in PROs. There were no complications either group, remarkably. Only significant differences were OR time, which was 34 minutes for the arthroscopic group and 22.5 minutes for the open group. There were 2 patients who underwent additional procedures in the arthroscopic group for debridement of the synovium or a radiocapitellum joint adhesion. So they conclude that there were no difference in the 2 modalities. but they recommended potentially open considerations due to the shorter operative time and less setup. So my question for each of the panelists would be, is anyone doing arthroscopic debridements, or have you all transitioned to open debridements based on this article? What's everyone's practice preferences at this time? Maybe we could start with Dr. Chalmers and go Dr. Tabuddy and then Sean.
I'm doing open for the reasons mentioned in this article. It's quicker. It's less costly. I think there's also the concern about cost.
I give them a choice. They typically choose arthroscopic. I do open if they're also unstable. I would point out that in order to conclude that something is not different from something else, you really need a non-inferiority trial, not a superiority trial that just failed to show superiority. So I think we have to be a little bit careful saying that they're the same. I wouldn't be surprised in a large study if maybe they are, though.
So I like to scope elbows. So I do it arthroscopically, and I do my repairs arthroscopically as well. I have to say that I found, since if we're allowed to say 10x and some other things have come out, that most of the lateral epicondylitis that I see has an instability associated with it. So we're doing repairs, and as Sean knows, I like to do my repairs with a scope. So that makes it an arthroscopic procedure for me, but I don't think there's any difference in open and arthroscopic. It's just more fun to scope it.
I would caution people listening that what Buddy just said is really critical. There's a large portion of patients who've failed non-operative treatment with lateral condylitis who actually have an instability problem that's been unrecognized. It's really easy to miss that.
That was Sean's description. We gotta give credit to Sean because he's the one that actually described the instability, found it, and most people probably don't remember, but initially we thought it was, or he thought it was mostly iatrogenic after failed open tennis elbow surgery. And then as we started tracking these people, we realized that an instability was the start, and the tendon failed secondary to the instability in some of these cases. And so that becomes something to look for. I would agree that that's critical.
Yeah, another third, pardon me, 30% of my patients have instability.
That's awesome. And I guess maybe since John, you described it, do you want to just real quick as we conclude this, do you want to talk about, sometimes it's obvious, but sometimes it's not so obvious, maybe how somebody can identify that when they have somebody who said failed lateral epicondylitis treatments and you're now considering surgery, how you can make sure that you're not dealing with an instability problem?
Yeah, so this brings up the issue of the exam. So for me, it's the clinical exam with the posterolateral rotatory drawer test, relatively independent of what an MRI shows. I say that because I have learned, I think, over the years what my confidence level is in my own exam. And I think the sensitivity is high. But on the other hand, there'll be patients in whom I or anyone else is going to potentially fail to demonstrate the instability due to guarding or otherwise. Under anesthesia, there'd be no guarding, but you still have to execute the maneuver correctly. And as with any clinical skill, like if you think about it, a skill in a certain sport, we have to be honest about our own learning curve with that skill. And what the people who are close to me and we work together would say is that I think we don't all have the same skill levels. So when I see a patient who has been operated on, they're told that they don't have instability of the elbow, they failed tennis elbow surgery, I don't assume that they're stable until I've examined them. And I, relatively speaking, I guess, frequently assume that they're probably unstable. But I take a video of it with everybody. And if we showed a video, if I just went and shared my screen and showed a couple of videos, you'd agree, yeah, that's unstable. There's no question about it. So my recommendation is that to you, those of you who are not yet experienced enough to be sure what your own sensitivity is with instability testing, I would say look at the MRI carefully, get somebody who knows what they're looking at on the MRI to help you read that if you're not sure yourself. And then ultimately, I imagine we're going to do a lot of sonographic stress testing. We've done some work with that, and that will probably be able to help people who have a lower degree of experience with it, I think.
The other thing to tell people is if you're going to do this case and you're not sure, you can consent the patient for, ECRB repair, debridement repair, inertial, whatever you want to call it, possible LCL repair or reconstruction, depending on what you think the tissue looks like. And then when the patient is under anesthesia, do a fluoroscopic examination. Stress the elbow under fluoro, take a look at it. If you don't feel confident in your own exam, do it on a day when you're operating next to a partner, a hand surgeon or a shoulder elbow surgeon, and say, hey, can you come look at these fluoro shots, make sure I'm doing this correctly? Do you agree the elbow is stable? And then you can feel much more confident and say, okay, well, we don't have an instability problem.
Yeah, and for those of you who may not rapidly acquire the numbers for experience, I would say get the opportunity to work on a cadaver where you cut the lateral clara ligament of the cadaver, cut halfway down, maybe be generous, cut a little more than halfway down, 2/3 of the way down through the extensor group and cut the lateral clara ligament as well, like you'd see in a tennis elbow, ECRB failure with LCL. It's sort of an exaggeration of it, so that that elbow should have a positive posterior lateral rotatory drawer test. If you cut 2/3 of the way down, it will. And then you practice the exam on that cadaver. You'll need the whole hand elbow unit up to the shoulder, and the shoulder will have to be stabilized so it's simulating in the overhead position. And if you practice that enough, I think you'll have a good sense about your skill level with it.
Fantastic. Fantastic. Well, thank you all very much. We've run out of time. This was incredible. I've learned a ton and actually can't wait to go back and actually rewatch this. You all are true masters. Really, really an honor to have you all. Clifton, anything you want to leave us with?
No, I mean, I thought I'm not awful at elbow scopes, and I clearly don't think about it the same way you do. So thank you everyone for that insight you provide to all our panelists.
Fantastic. Have a good night, everyone. Thanks for tuning in.
Yeah.
Thank you.
Thanks, everyone. Good night.
Thank you, everyone. Good night.